You were focused very strongly on, or you mentioned CBT, computerised CBT, and that seems to be a cheap way, an inexpensive way of delivering therapy to lots of people. Is it as good as just having people in a room, or is it better than having people in a room? And perhaps is that a better way of delivering therapy maybe to people who don't want to be in a room with lots of other people? So.
I mean, specifically for computerized CBT, we know that the effects vary quite a lot. So there are a lot of studies out there that show that CCBT, as it's known, could be as good as face-to-face therapy. And there are some UK-based large trials, most of them done by Simon, that actually showed that CCBT does not work at all, even compared to sort of nothing, waiting list. And really the trick here is whether people do it or not. So if they engage and they complete the CCBT program, they can have the same effects as if you have someone talking to you face-to-face. But we know that if computerized CBT is not supported by a clinician or even a non-clinician who can offer the adjunct human support, then people do not engage with it, and of course they do not get better. So I don't know if this is...
Brian, do you want to just chip in and say that?
We don't know anything about the effectiveness of these sorts of interventions for adults with autism, so I can't really comment, I'm afraid.
Yes. Okay.
Thanks, Alex. Great presentations, really enjoyed them, and great event, Jess. Can I ask you, if there's going to be a bid, say, across research councils from York on mental health soon, what might the theme be to unite it, and what would you like to see in it briefly?
That's a great question. Okay. Who's first? Because you're all going to have to...
I think it would be great if any bid considered the issue of prevention.
I would say digital.
Yeah, good.
I suppose for me, I think that there's something about working across interfaces and boundaries, because I think that's where people fall down. I work for Tees Esconway Valley's NHS Trust, and there's lots of interfaces which I think are barriers for people. So there's always an issue about people, the accessibility of interventions and making things available to people in a way that they can use them. And I think that if we can get to more people, then that's how we would make a difference. So something along those lines would be my shout.
Well, not being an expert on mental health at all, but an expert on public policy, my view would be that, and maybe it might be a view of ignorance, but I think from the research we've done, I think any of the problems in terms of mental health won't be resolved unless you resolve the political questions about how services are funded, how they're organised, how they relate to each other, how users are involved in those organisations. So I think actually a lot of the barriers to health solutions are actually political, and we need to see how organisations work together if services are to be effective.
Yes.
Hi, I've got a question for you, Martin, about the police training, which I thought was really interesting, because I'm very much aware that they do tend to be the first point of contact for people's mental health difficulties. And I was wondering, could you guide me towards any research that might have been undertaken on the police officers, sort of like the first contact people within the police, as to how they perceive that training's been of benefit to their officers on the ground?
Yes, Martin.
Martin. Oh, okay, go ahead. Yeah.
In brief, the papers are in press. We evaluated the intervention, the training intervention. It was very positively received by the police officers. It's currently being written up, be in the public domain very shortly.
Does this work? Hi, it's Terry Smithson from Yorkshire Wildlife Trust. A question for David, really. and maybe an offer. We've got 600 volunteers across Yorkshire, and many of them come to us with very low Warwick Edinburgh scores. So perhaps in terms of recruitment, that can help you. Really welcome the thoughts around prevention. Obviously, a lot of the cash at the moment goes toward acute for good reasons. So I think some analysis around where we can help to prevent that would be great. Something around boundaries is really good as well. So welcome those ideas around future funding. I guess the question for me, though, is looking at your studies, to what extent will it look at the provision, I guess, so within our volunteering network, lots of people work in our nature reserves, but amongst other things as well. So to what extent can you look beyond, look into those areas where the provision is made, I guess, and to what extent that can be scaled up in terms of resource and ability to provide more of those services?
Well, I think that that's a good question. I suppose there's always a challenge with research, isn't there, about the ability to focus it enough to be able to answer the question that you're asking, and then from there, how can you take that further forward? So I think the reason that we looked at community pharmacies was particularly because of the placement of community pharmacies across the country. And what we know about community pharmacies is they are disproportionately placed in poorer communities. So really they are an access into those areas where perhaps other elements of the health service are disproportionately not placed. And so we are particularly targeting those community pharmacies. And also in terms of long-term health conditions, virtually everybody with a long-term health condition will have contact with a pharmacy. And so in terms of reach for that target population, it's great. But the people that we're training to deliver the health promotion, they deliver other health promotions, but they are a kind of new band. And I think that if we can show that we can effectively deliver health promotion in those settings, then it will open doors, I think, for lots of other settings where they have a similar set of workers or people who might be able to provide a similar service.
David, could I just? I was wondering what happens when people, how this works exactly. So someone goes into the pharmacy, into the chemist. What's the interaction that happens? Is the chemist trained to spot people with chronic mild depression and say to them, you look a bit under the weather, and have you considered doing this? What's going on here?
Right, okay, I'll try and be brief, Jess. It's an interesting thing. So one of the challenges we've had in recruitment is that if we rely on the pharmacists, like if we rely on the GP in primary care to select participants for research, it's a really slow way of doing it. So we have various routes. So the pharmacists can talk to people through their various contacts they have, medicine use reviews and new medicine services. The counter staff can talk to people, but they find that quite a difficult thing to do. So we tend to distribute information quite widely. We're learning that actually is a much better way to get to people and to give people details of the study. So we are replicating what we would do in primary care, which is mail outs. And what we're finding with that is that works much better in terms of reaching out to people to give them the information about the study. The pharmacies find it quite difficult to have those conversations on the shop floor.
0 minutes. Wow. Okay. Well, no, because it's okay. You don't have to march to Jess's drum all the time.
My question is just, how important do you believe service users to be in your research studies? And if you do believe that they're important, how important and at what stage in the process do you think that they should be involved?
So with our study, service users were involved. Well, they weren't service users, they were just adults with autism. Were involved in crafting the research objectives, so from before we sought funding. and their involvement has continued. So we have a panel of adults with autism who we met with to design the interviews we did, the tools that we used to facilitate those interviews, and then we've met with them to tell them how we're interpreting the findings, and then we'll be working with them in terms of disseminating the findings. They have to be there.
Yeah, for us, I mean, involving children and teenagers in developing the interventions is quite important. Otherwise, the interventions are not fit for purpose, especially when it comes to sort of digital media. They come up with stuff that I'm thinking, oh my goodness, that's a revelation. And they look at me as if I'm an alien, that I didn't know that. So I think it's genuine ignorance that unless I don't have young people around to tell me that this is how it should be done and this is what should be included, otherwise it won't work, then I think we're just really flogging a dead horse. So it is important to have bottom-up approach with children and young people being involved from the beginning in developing the intervention, evaluating it, interpreting what we find, making sense of it all, and then telling us how to roll it out.
Yes, just the same. Very important from the design all the way through to the dissemination, and you know, using the expertise to help us get it right. It's a core part of the process.
Well, in one sense, we had one set of users, which were the police officers, who were continually involved in the project. And I think that was very important because we were trying to develop research that actually would affect the way they worked. We did involve some users of mental health services, but the project had to be done in a very short period, so there wasn't, I admit, not enough involvement. But I think a very interesting project to follow up actually would be the extent to which users felt the benefit of police training, which I think is another research project to be funded.
Yeah. Thank you. Okay, we've run slightly over, but I think we could thank all our speakers again for the valuable talks.